And turn on my pointer here. Okay, so I'd like to discuss the Nonin RespSense Capnograph. Excuse me. These are slides that we use from, or we obtained from the Nonin rep years ago. Definition: Capnography is defined as the measurement of carbon dioxide and exhaled breath. It only provides monitoring of ventilation. It is not a methodology for establishing oxygenation in a patient. Is what oximeters are for, and the next couple of slides will go over why we use oximetry and how it works. So here's a quick oximetry review and advantages of oximetry, and then concerns we have with the measurement of oximetry as well. Now I'd like to review capnography, and basically what we're looking at is this is a breath-to-breath indicator of the accuracy of respiration, circulation, metabolism, and CO2 elimination. And it really kind of works off, it's an indicator of the adequacy of metabolism, perfusion, but not only these, of ventilation. That's the one that's the biggest concern to everybody when we're using moderate to deep sedation on patients, is how effectively is the patient ventilating. Now, there are two methods of capturing this gas. One is side stream, one is mainstream. The RespSense device uses side stream, where it pulls gas out and measures it using light. The advantage of this device: immediate feedback. It can be used in a non-invasive manner, so you don't have to obtain ABGs and put the patient in discomfort. It's pretty good adjunct assessment of cardiopulmonary status, how well you're doing with your ventilator management. The other thing is, the cost factor involved here. If we were to have to draw serial ABGs during a procedure, or we were to put the patient on a Untitled CO2 monitor, it is far less expensive to put them on an Untitled CO2 monitor. One of the biggest concerns of capnography, of course, it is not as accurate as the CO2 that you obtain from a blood gas. So it can range. I mean, the screen tells you 2 to 5. I've seen it higher or lower depending on how well calibrated the device is. Our devices, our RespSense devices, are calibrated annually, and that is, you know that because of the sticker on the front that says it was calibrated. So you know that device is fairly accurate. They will go out of calibration though, so if it's significantly off, we need to fill out a work order and start that process to bring the device back into calibration. A couple of slides here just comparing capnography with pulse oximetry. Big one here is, when we're looking at oxygen changes, it can be anywhere from 1 to 3 minutes depending on cardiac output and circulation. Whereas with capnography, we see changes in ventilation fairly quickly. They claim within 10 seconds, but definitely faster than 1 to 3 minutes, I can tell you that. The waveform, a lot of you have seen this classic square-shaped waveform where at the beginning of exhalation, they call it section A, section B. Then it moves out of early exhalation, or the ascending phase of early exhalation, so we're moving up to C, so up here. Then we plateau, so there's really kind of an equilibrium here of gas, and so this is where true measurement's occurring. And then when we get to the D phase, that really is your end exhalation, is right there. So with that, we see as we come out of D phase back into this E phase here, and then thus into A phase, this is basically your inhalation right here. So you want to see a rapid decrease in the amount of CO2. And this is what a normal waveform looks like. Nice little tilt there, moving to maximum NX tidal. This is your equilibrium. And the normal range is anywhere from 35 to 45. You get a lot of questions about this a lot of the time, so just kind of keep that number in mind. Just some examples of what hyperventilation, hypoventilation would look like with waveforms. And again, just kind of bring it into one slide presentation what hyperventilation and or hypoventilation waveform would look like possibly. Just a table here that lists elevated CO2 factors and decreased CO2 factors for end tidal, and it just goes through again what it talked about earlier: respiratory, metabolic, medications that might impact it, and then from a circulatory standpoint, what might affect it. So with elevated end tidal CO2, shivering or bicarbonates, with decreased end tidal CO2, bronchospasm, or airway obstruction, we're not seeing flow. So reading through these, you pretty much put it together. Yeah, that makes sense, but it's a nice little graph here for you to use to remember what affects or what can affect increases in end tidal CO2 and decreases. So the RespSense end tidal CO2 has both numerical and waveform value reading, and it has a respiratory rate and a high-low alarm, and it trends end tidal and respiratory rate as well. Here's a nice little picture of it right here. There's a picture on this next slide. This is what the screen looks like. This is where your patient interface is. Moving up to the top here, this is your on-off button. This is your alarm pause button, and when the alarm pauses on, this little alarm with an X through it will show up. Charge indicator right here. Here's your battery indicator right here. This is all touch screen, so increasing and decreasing these values is piece of cake. Just push up or down for your end tidal CO2. And for your respiratory rate, here's your Capnograph waveform, and this is a trending area. So it's kind of cool. Back of it, we see the moisture trap, and then this is where our sample connector goes so it can interface with the patient. This water trap we need to make sure this is in place and tightly in place, because if not, it creates leaks in the system and you won't get correct reading of the end tidal, and you'll start seeing alarm packages develop. So this is what the moisture trap looks like from the side and how it fits into this little triangle shape area. Here's a closer look. There's a water trap, or a filter, excuse me, that goes on top of the water trap. This can deteriorate over time, and you'll start to see occlusion alarms for it. So if you see that, change out the filter, and it should make that go away. Also, if this is not seated in here correctly, you'll start to see occlusion alarms ringing as well. So startup screen, when it first starts up, it gives you a selection between alarm package, no alarm. We press alarm, and then it's going to ask, what is the size of your patient? Under 30 kilograms, over 30 kilograms. Setting alarm limits, I stated before, all you do is push up and down for the high and low respiratory rate, or I'm sorry, for the high rate, and up and down for the low rate, and then same thing for the end tidal, for the high end tidal and for the low end tidal. You're going to set this based on your pre-assessment of the patient, where their average end tidal was looking before the procedure, and you'll adjust accordingly. So these slides are going to go over some high priority alarms and causes, end tidal, respiratory rate, and no breath. If no breath is detected for approximately 25 seconds, that's probably a high priority alarm. So you need to be looking at your patient and probably taking corrective measures. And again, this one kind of shows some low priority alarms and then causes of low priority alarms that can occur with the RespSense by Nonin. This is just the manufacturer's list of product advantages of the RespSense. I'm not going to bore you too much with it. It is rather convenient. It is fairly fast in its assessment of what end tidal CO2 is. I will give it that. But the rest are just kind of some props for the product by the manufacturer. Here's a nice little troubleshooting supplement sheet that we'll have available for people to review if so desired. This is the check-off sheet by the company. Not of any importance to us right now. If you have any questions, you can either catch me in live action, or you can email me at owen.seats@stalphonsus, all spelled out, .org. Thanks for listening.